Bioimpedance guided fluid management in peritoneal dialysis, a randomized controlled trial. Volume overload is associated with hypertension, cardiovascular events, morbidity, and mortality, occurs more frequently in peritoneal dialysis than hemodialysis. Bioelectrical impedance analysis devices have proven to be helpful for the clinical assessment of fluid overload. This BIA-guided fluid management could improve short-term outcomes in patients on peritoneal dialysis. A prospective, single-center, open-labeled in Guangdong, China. Followed up for 1 year. BIA versus traditional clinical methods. Included continuous ambulatory peritoneal dialysis treatment more than 3 months and with fluid overload defined as an extracellular water and total body water ratio more than 0.4. They excluded contraindications to BIA measurement, severe heart failure, acute complications and severe malnutrition. The primary endpoint was all-cause mortality. The secondary endpoints were cardiovascular disease and technique survival. Technique failure referred to a situation where a patient receiving PT switches to hemodialysis for more than 3 months. In control group, fluid balance was adjusted by traditional clinic measures like body weight, blood pressure, edema, signs and symptoms of chronic heart failure or hypovolemia. In the BIA group, ECW and TBW ratio more than 0.4 were used to determine fluid status. All were asked to restrict salt less than 5 grams day and water intake. If urine volume more than 200 milliliters day, diuretics were prescribed to increase urine output. More hypertonic dialysate, shortened night dwelling time, or intermittent PD was recommended for increased water removal. Automated PD and icodextrin were not used. The estimated sample size was 240 to provide the trial with 90% power in all-cause mortality at 1-year follow-up. Intent to treat approach. Patient and technique survival were calculated using the Kaplan-Meier method. 120 patients per group. No differences in baseline characteristics. Follow-up 32 months, mean UF 450 milliliters. A significantly fluid control target were found in the BIA group, 55% versus 35%. The serum NT-proBNP level decreased significantly in the BIA group. The overall patient survival was not statistically different between groups. Cardiovascular mortality also showed no difference between the two groups. No significant differences in technique survival rate. The authors extended the analysis to 3-year follow-up, where patients in the BIA group had a significant better cumulative patient and technique survival rates. BIA-guided fluid management was more effective to achieve fluid balance, but there was no difference in patient and technique survival and CVD mortality. Kidney Today. Thanks for watching.